The Treuman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle presents its second annual conference, Ethical Issues Related to Vaccination of Children. The Treuman Katz Center is the nation's first center dedicated solely to the study of research and healthcare for children. During this 5-part television series, national experts discuss vaccine policy, parental rights, and global controversies surrounding childhood vaccinations. In this program, Dr. Lainie Friedman Ross, Associate Director of the McLean Center for Clinical Medical Ethics in Chicago, tells the controversial Rotazyme story, When Are Double Standards Justified? Dr. Douglas Diekema, Director of Education at the Treuman Katz Center for Pediatric Bioethics at Seattle Children's Hospital, introduces Dr. Lainie Friedman Ross.
Dr. Ross is the Carolyn and Matthew Bucksbaum Professor, which is a recently endowed chair at the University of Chicago. She's a professor in the Department of Pediatrics there and Associate Director of the McLean Center for Clinical Medical Ethics at the University of Chicago, where she is also the co-director of the Ethics Case Consultation Service. She was also recently named the Section Chief of Community Sciences in the Institute for Molecular Pediatric Sciences. Dr. Ross received her pediatrics training at Children's Hospital of Philadelphia and at the Babies Hospital of Columbia University in New York City. She earned her master's in philosophy and her PhD from Yale University, and she currently serves on a number of national committees and DSMBs and federal advisory panels. Dr. Ross is a return visitor from last year's conference, and she's going to speak to us this afternoon on the rotavirus vaccine story, When Are Double Standards Justified? Lainie Ross.
Thank you. I want to begin actually by thanking the organizers for inviting me back. I also want to welcome Ben as the new director, but I want to actually congratulate Doug because I think the idea that we're talking about infectious diseases today is great. So it turns out that there's something known as the 10/90 divide, which is that 10% of medical research funds are spent on the diseases that account for 90% of the global burden of disease. And there's an article written in Bioethics last year which charged that bioethics apparently suffers from a misdistribution of research resources analogous to the 10/90 divide. And the article is basically a complaint about why bioethicists have ignored infectious diseases. And Dr. Selgalid, if I'm pronouncing his name right, argued that it really should be. Infectious diseases should be very important to bioethicists for 3 reasons. 1, the significant impact that infectious diseases has on health of all of us. 2, because it raises very interesting issues about public health versus individual autonomy. And 3, for the justice concerns. And this is particularly important given that the burden is most heavily shouldered by the poor in developing countries. So it's actually very exciting that I get to talk about the rotavirus vaccine and the story about whether bioethicists missed the boat, as suggested by Dr. Wickler this morning, or whether it's actually the politicians who missed the boat, as well as other stakeholders, including the manufacturers of the RotaShield vaccine. So that's what's going to be the topic that I'm going to talk about, is sort of the history of the development of rotavirus vaccines and the political and ethical questions. And I'll argue that ethicists are not the main problem in infectious diseases. So on that note, so let's start with rotavirus. So again, as I was just introduced, I am a practicing pediatrician, I am a philosopher, so I get to have both the in-the-trench perspective as well as that bird's-eye perspective, and hopefully that'll show you, in a sense, how this problem really should have been addressed in the past decade. So rotaviruses are the single most important cause of severe diarrhea in infants and young children in both developed and developing countries. It's often associated with severe vomiting, which makes for oral rehydration therapy to be less successful than for other causes of diarrhea. And it's responsible for about 35 to 50% of severe diarrhea diseases, meaning those that will end up requiring hospitalization. And in fact, in the US, they're responsible for over 500,000 visits to physicians on a yearly basis, 50,000 hospitalizations, and 20 deaths. In the developing countries, it's approximately 111 million episodes of diarrhea annually, 25 million clinic visits, 2 million hospitalizations, and 400 to 500,000 deaths in children less than 5 years of age. So if we want to talk about where the burden of the disease is, I think that's pretty obvious. So the history of the development of a rotavirus vaccine actually goes back 2 decades. And the first attempt was one called RIT-4237, which was administered to Finnish infants using something called the bovine Nebraska calf diarrhea strain. And it actually resulted in substantial protection against rotavirus diarrhea that lasted for over 24 hours in the Finnish children, but it actually faltered when the results were not reproducible when children who were enrolled in trials in several developing countries, including Peru, Rwanda, and Gambia, and in a sense, this vaccine just goes off the market. No further attempts are done. There's a second attempt using a rotavirus vaccine using MMU 18006, and this was also again studied. It was given orally to over 1,500 children between 1 and 20 months in the US and overseas, and had actually a very variable efficacy rate, anywhere from 0% to 85% against moderate to severe disease. And that's really all we care about is moderate to severe disease. I mean, kids get many gastroenteritis infections during their childhood, and as long as we can oral rehydrate them, we really don't care about it. The only thing we want to prevent is those that require, in a sense, hospitalization and intravenous fluid. But one of the things they realized in studying the MMU 18006 was that they thought that this suggested that you might need specific serotyping in developing the rotavirus vaccine. And so then we get to the third attempt, which is used a quadrivalent rotavirus vaccine. And this was known as RRTV. It's a rhesus-based rotavirus tetravalent. And it actually had some very good success. And here are some of the studies that were done to show that, again, looking at the number of individuals versus placebo. So large number of individuals were enrolled, and what you saw that it had somewhere around the 50 to 70% efficacy rate in protecting from all rotavirus diarrhea, but more importantly, a 70 to 100% efficacy for severe rotavirus diarrhea, and really prevented dehydration over 3/4 of the time in all of the studies that it did. And so with this type of data, the US Advisory Committee on Immunization Practices recommended routine immunization with 3 oral doses at 2, 4, and 6 months of age. And in fact, 6 months later, the US FDA granted a license to Wyeth Labs for manufacture and distribution of the RotaShield vaccine. One of the good things about our health system, and there's a lot of things I can say negative, but is that we do have post-marketing surveillance. And so between September 1st, 1998 and July 7th, 1999, 15 cases of intussusception post-vaccination with RotaShield were reported to the Vaccine Adverse Event Reporting System, which is a voluntary reporting system. And at that time, it was estimated that approximately 1.5 million doses had been given. And although the number of cases reported was within the expected value, it was of concern that 11 of the 15 cases had occurred within 1 week of administration of the first dose of vaccine. So the fact is that we don't exactly understand the pathogenesis, but children who actually have rotavirus are at increased risk of intussusception. And there was data from New York State that suggested that about 51 in 100,000 children with rotavirus vaccine went on to have intussusception, which is when the colon loops back on itself. And so they didn't think that the number was that outrageous, but the concern was, why was it happening within a week of the first dose of vaccine? And the CDC at this time recommended suspending further vaccination until further data were available. So it's interesting, when you go back to look at the pre-licensure data, it turns out that 5 of the over 10,000 infants who received the rotavirus vaccine, and 1 in the placebo group, had developed intussusception pre-licensure. But none of them had developed it after the first dose. It's also interesting that the pre-licensure studies failed to demonstrate an etiological association between this, and so therefore didn't have to do anything about it, but did choose, in a sense, to describe it on the package insert of the RotaShield vaccine. because they did think that it was an important thing to at least acknowledge. In October of 1999, the CDC and the ACIP have a meeting where they actually now have 102 confirmed or presumptive cases of intussusception that have been reported to the VA ERS, and 57 of them, so about half of them, are within the first 7 days of vaccine, and 46 of those were with the first dose. And so their conclusion was that intussusception occurs with significantly increased frequency in the first 1 to 2 weeks following vaccination with RRVTV, particularly following the first dose. And with all of that, the ACIP withdrew its recommendations for use of RRVTV in the United States. Given that, remember, the risk of serious illness in the United States is about 20,000 hospitalizations and 20 deaths. If this is a serious risk, and intussusception can lead to significant morbidity and mortality. So in this country, the decision was that the risks outweighed the benefits, and it can no longer be recommended. But that's not necessarily the case around the world. And so the World Health Organization held a meeting on February 9th to 11th in the year 2000, and they asked 5 very important questions. Could a vaccine withdrawn from the US market be used in developing countries? Should testing a vaccine with known adverse risks that can be fatal be supported? If so, what safeguards are necessary? Is it ethical not to use a vaccine that could prevent a large burden of fatal disease? And 5, how should new candidate vaccines be tested? So one of the issues that this whole thing raised was, well, it might not be very useful, this vaccine in this country, it might be very useful in developing countries, and so how should new candidate vaccines be tested? Should it be sequential or simultaneous? So could a vaccine withdrawn from the US market be used in developing countries? So the ethical argument against it is justice as equality, that geographic location and economic status should not be a basis for determining what justice requires. Children in the developing world are the same, are on equal footing to their counterparts in the US, and if it's not safe enough for US children, it shouldn't be safe enough for anyone else. But there's the other ethical argument, and that's what's important. As Dr. Wickler said, ethicists don't have to make policy, so they can point out what are the ethical arguments in favor and what are the ethical arguments against. And I actually think the ethical arguments in favor of not withdrawing this vaccine in the developing countries are quite powerful. And that's using a different notion of justice. And it's using a notion of justice based on equity, which says that justice requires that alike be treated alike. So this doesn't require treating everyone the same. And rather, it acknowledges that you must take into account the economic and social context. And since the severity of disease is different in the two communities, different standards are permissible. So different standards rather than the more pejorative term of double standards. So yes, double or at least different standards may be appropriate. So I would agree with all of the philosophers who say there's only one universal ethical standard for research ethics. We can sort of look at the 3 principles in the Belmont report because it's actually one of the better documents that I've read, and it really begins with this whole notion of respect for persons. That we have an obligation to respect the autonomy of competent individuals, but those who are not competent, like children, we need to protect them. And so given that, there's one ethical standard, and that standard holds whether you're a child in Gambia or a child in Chicago. But even if we accept a single universal standard, we could still argue that it permits different trials for different countries, recognizing that the principle has to be applied differently, given the diversity, the drastic differences in the local circumstances. And I think it is important to think about the whole rotavirus vaccine and the whole decision by the developing countries to not want to go on testing the RotaShield vaccine by looking at what had just transpired in the mid-1990s, which is to look at the trials to reduce the vertical transmission of HIV in Africa as a case study of whether double or different standards are ethical. So the trial that Dr. Wickler was referring to this morning is known as the ACTG 076 study. It had an enrollment criteria of enrolling all HIV-positive women between their 14th and 34 weeks of gestation. So not including them in their first trimester because it was going to be giving a drug that could potentially have some teratogenicity. And these women had to be very healthy, meaning they had to be HIV positive, but they had to be asymptomatic. So they couldn't actually have an AIDS-defining illness. And so therefore were not at need for any therapies for themselves during the current pregnancy. And the protocol was going to be oral AZT of 100 milligrams 5 times a day, initiated at enrollment, and this was here in the United States. And during labor, these women would get 2 milligrams per kilogram of AZT in a 1-hour bolus through an intravenous line. And then the newborn would get 2 milligrams per kilogram 4 times a day for the first 6 weeks of life, beginning 8 to 12 hours after birth. So a very intense protocol, one that required a lot of resources and a lot of ability to be able to give these medications over this prolonged period of time. And the results were incredible, as we all know, that it reduced the risk of getting HIV, the vertical transmission, by 2/3. So instead of having a 25% risk in the placebo group, those who got treatment had a risk of about 8.3%. And this was published in the New England Journal in 1994. And immediately, these results became standard of care in this country. And it was expected at that time that it would prevent about 600 to 1,200 cases of HIV-infected newborns yearly. And the cost was estimated at that time in 1994 dollars at $800. And HIV-positive women were also discouraged from breastfeeding, something possible in this country and not really feasible in most of the developing world. It was also acknowledged that an $800 course is prohibitive in all developing countries and was not and would not be implemented. And so the issue then came, there was a universal consensus, we need a shorter, cheaper protocol to decrease vertical transmission of HIV in the developing world where HIV is a much larger problem. And the controversy that came up was the study design, how to determine ethically a safe, effective, and cheaper protocol. So you had 2 possibilities of study design. One is you can compare AZT course as developed in the ACTG protocol against the short course. The other is to take a short course of AZT and compare it against placebo. And the short course was only going to involve 4 weeks of oral AZT. Remember, the long course involves a lot of intravenous, which again may be prohibitive in much of the developing world. And it was also require a large oral dose in labor. So comparing the long course versus the short course is much more expensive, and it's not clear that it helps those in the developing countries, because it's not as if they actually have the option, would you like long or short course at the end of this trial? They're going to have the option of short course or nothing. And so option number 2, in a sense, is really the question that these countries needed to ask, which is a short course at all worthwhile? Are we willing to put in the resources for a short course? How effective will it be? Will it be as effective as a long course? Probably not, but the real question is it better than nothing? And do the benefits outweigh the costs and risks? And so the questions that come up when the question of which study design to use were, number 1, is it ethical to use placebo trials to determine whether this short course will work in developing countries? And is it ethically relevant that such a study could not be done here in the United States, where at that point, within weeks of the New England Journal article, it became standard of care, and every single woman who was HIV positive at an OB's office was being offered AZT. And then came the question of, could you even get informed consent when the subjects aren't being offered the standard of care? So in my traditional informed consent as a research individual, the question is, here's what we're offering you in the research, and here's the alternative. Outside of this research protocol, you can get a long course of AZT if you lived in the United States. Isn't going to be very helpful to most of the women in the developing countries. And so these are 2 very different study designs, but I would also argue that they're not equivalent, that they answer very different questions. The short-term versus long course is really asking, is the short course as efficacious as the long course? But that's not really the issue that individuals in the developing world needed to know. They needed to know, is a short course of AZT better than nothing? And how much better is it worthwhile for us to be implementing? So I would argue that the placebo-controlled trials are ethical if they're being used not just because it's cheaper to do, because it's clearly cheaper to do a short course versus nothing than a long course versus the short course, because there, in order to prove a difference, you're going to need a much larger sample. And it's also the placebo arm is a lot cheaper than the long course arm. So I would argue it's ethical to do a short course versus placebo if the goal is that it's going to help the community in which the research is being done. It's also important to realize that as these studies were being discussed and as this whole question of the research was being done, we didn't know exactly what the vertical transmission rate was going to be in the developing countries. In fact, there was a theory that it would actually be higher than it was in the United States because there would increased risk for anemia, malnutrition, and various infectious diseases, which the thought was would make actually the vertical transmission more likely. So the question was raised, and the answer is that the research was done as a placebo-controlled trial. And we actually learned that the vertical transmission rate without any treatment, so in the placebo arm, was actually lower than in the US. So where in our AZT trial of ACTG-076, the vertical transmission rate in the placebo arm was 25%, in the first studies that came out, short course versus placebo, the placebo arm had a 19 to 20% vertical transmission rate. And this is really important because if we had found that the short course gave us a vertical transmission rate of 20%, comparing that to our original data, we would say, well, for 1/10 the price, we can get a 5% reduction. When the answer really would have been, for $80, we would have gotten absolutely no improvement. So we really needed to know what was the likelihood of vertical transmission in the population in which this study was being done. And we did find that the short course was effective. It didn't get down to the 8% as the long course did, but it got down to about the 10 to 12% rate, which was about a 50% drop for those women, given that in the placebo arm they were running around at 18 to 20%. So it was really important. The data came out, was very useful, and again, is it ethical? Well, the question is, was the research being done to benefit the community in which it was being done? So the results were useful in the US for women who presented late in pregnancy because there was now data to suggest that treatment during labor and delivery could change the risk of vertical transmission. So even if you had no prenatal care, as you walked into the hospital, we could start treatment. But if that were the only benefit and that were the only use in all of these trials, would have been absolutely unethical. It's okay as a secondary gain, but the primary gain had to be that it was going to benefit the women in the developing countries. Well, it turned out that very few countries considered implementing the short course because $80 was still too expensive. And in fact, had people spoken to the stakeholders, they would have known that. And it suggested then that the study designers hadn't done their homework. To justify the whole study of a short course versus placebo, one needed to ensure that the results could be implemented. Otherwise, we did do more harm than good. And so this was a really upsetting set of studies for me, because over the period of the data coming out and understanding how that it couldn't be implemented, it became clear to me that, in a sense, these were American researchers who were, quote, imposing our ethical standards or whatever you want to say, but that we really hadn't engaged the communities in which this research was going to be done. Or we would have known that we were not asking the real question that needed to be addressed, which is, can we come up with a course that's affordable, that could be implemented, and does that course, in a sense, offer any benefit to the communities in which we would do the research? So it's on that note that we have to then go back to, should we have continued the RotaShield vaccine studies in the developing world? So at this February 2000 World Health Organization meeting, when that was the question, even if it's being taken off the market here in the US, should we continue studying this, or at least start to study this in the developing world? Charles Weiser argued in favor of double standards. And here were his arguments. Failure to proceed with further trials of RRVTV would further any existing inequities in health between developed and developing countries. The data developed for RRVTV far exceed the data available on other rotavirus vaccines, and so by continuing with the RotaShield, in a sense, we don't cause a time delay. Inaction, waiting for comparable data on other vaccines, is not morally neutral, since the disease burden cannot be ignored in the interim. If we have to wait 7 years, which is what we ended up doing, 3.5 million children will die. So that's the number. 3.5 million children suffered needlessly, I'll add, because we decided to do inaction. And so his answer was it would be immoral not to proceed with the RRV-TV in developing countries. But he added a caveat that we learned from the HIV story, which is further study of the vaccine in developing countries should only proceed with assurances that the vaccine would be available for general use should the results of the trial prove to be positive. So if we found that this really reduced the burden of disease, one, we needed assurances that the manufacturers were going to continue making it, despite the fact that the more lucrative markets were not going to use it. And two, we needed to know that it was going to be at a rate that was affordable to the communities in which this vaccine would be used. Now, the big difference, in a sense, between the original AZT trials and the RotaShield trials is, in a sense, the Bill and Melinda Gates Foundation. Because with the Bill and Melinda Gates Foundation, the financial issues of how expensive the RotaShield vaccine is becomes less important when you get promises of financial support for these vaccines. And we will get back to that. But before I get back to that, I want to just point out when people say double standards, we shouldn't have them. The fact is we have huge double standards right now in the world of infectious diseases. So what I've done here is given a list of different vaccines and how they're being done in developing versus industrialized countries. So the developing world is still using DPT, where we've moved to DTaP because the acellular pertussis component is much safer. And in fact, we don't just offer it as DPT, we now do DPT-Hib combinations because it might be more expensive, but parents prefer one vaccine versus two. It's a luxury. Hepatitis B, while commonly used in the industrialized world, is very uncommon in developing countries. But the next really interesting one is the polio. Although we had hoped to eradicate it, and with all the conflicts in the world today, it looks less and less likely. The fact is as we got rid of polio in North and South America, we moved from an oral polio vaccine, which puts children at risk for vaccine-associated paralysis, and we moved to the safer vaccine, which is only adequate if you really don't have a lot of disease in the community. And yet in the developing world, they continue to use a live polio vaccine. And so the idea that double standards were something sort of unique to the RotaShield is outrageous. We have we have right here just over half a dozen examples of the divergence of recommendations for vaccines based on local circumstances. So the double standards are mainly due to expense. And in fact, one of the big concerns is there may be little incentive to create vaccines for diseases only in the developing world, like TB, malaria, and cholera. And there's little incentive to create vaccines that will be used only for developing world, like RotaShield. So one of the concerns when we moved to the DTaP was whether the vaccine manufacturers of the DTP, a much cheaper formulation than the DTA cellular pertussis, would they stop making it? Because the market, again, is much more lucrative here in the United States. And as I've already pointed out, although the EPI had achieved about 80% coverage, for example, in 1990, it's down to about 50% by 2000 due to political unrest in many parts of the developing world. So the fact is, not only is there this, quote, double standards, or at least different standards, there's also huge double practices that exist. The outcome of the WHO conference was that actually WHO recommended that research continue with RotaShield in the developing countries. But despite these recommendations, representatives from developing countries had no desire to evaluate RRV-TV because of the ACIP recommendations. So it wasn't the ethicists who caused the problems, it was the politicians, and they did it claiming to be on the moral high ground. And so they said, ACIP, you have three options, help us. Change the vaccine back to routine use. The answer was highly unlikely. The burden in the United States just doesn't justify it. How about give us a permissive recommendation, which would, in a sense, remove the barrier? And it was becoming actually a possibility because the follow-up to these meetings was that we learned a lot more about what the real risk of intussusception is, and it turned out to be a lot lower than the first predictions. The first predictions was that intussusception was occurring in about 1 in 2,500 vaccinees, and it turns out that by the end of the studying of the post-licensure data, that it's about 1 in 10,000 vaccinees. But they felt that at least if ACIP gave a permissive recommendation, then we wouldn't be treating children in the developing world differently, that they would be on equal footing to their counterparts. Something no one's talking about with oral polio versus IPV, and no one's talking about with DTP versus DTAP. And the third option, which was a statement indicating that the risk of intussusception was considerably less than the original projections. And this ACIP was willing to do, but that was probably not going to remove the barrier, because it goes back to step 2, which is we want our children to be viewed on equal footing as children in the US. And so it was a political statement which looked like a political moral high ground, and it was done on the backs of 3.5 million children. So in October of 1999, the CDC presented data indicating that the overall risk, as I said, went down to about from 1 in 2,500 down by April of 2000 to about 1 in 12,000 cases. So an almost 5-fold reduction, which may have led to very different policies, but still probably unlikely that we would use this vaccine in this country given the low burden of disease. So the demise of RotaShield, ACIP did not change its recommendation. Wyeth stopped manufacturing RRVTV, making further trials impossible. But of note, it's that the RotaShield costs $38 per dose in the US, or in a sense over $100 per child. And that would have been prohibitively expensive. And yet at the same time, we are developing innovative strategies to, in a sense, address this disparity and to have made it affordable had the studies gone on. With the withdrawal, there was a reassessment of the future of the live oral rotavirus vaccine, because it wasn't known whether any of the other vaccines would have the same, a greater risk of intussusception, or lower. And at the time that all of this was happening, there were actually 7 that were at different stages of development. And as you can see, the first 2 are the 2 that we're going to actually end up talking about, Merck in the US and GlaxoSmithKline in Belgium. One was a pentavalent human bovine reassortant. The other was a monovalent attenuated human strain. This has the advantage of having 5 different strains, and we've talked that that might be useful. This is the attenuated human strain, which it turns out is better uptaken in the gut, and so has a higher efficacy rate. So they both have their own strengths and weaknesses. And in December of 2004, the status was that over 60,000 children were being tested in phase 3 trials. And efficacy was still pending in the RotaTech, but there was clearly 90% efficacy of preventing severe diarrhea in Venezuela, Brazil, and Mexico. But clearly other places were doing things, for example, China, which was manufacturing its own, which is another big change in the past 5 to 10 years, which is the development of manufacturers in the developing world itself. There was also this whole issue of the neonatal human strain, which again probably wouldn't be very desirable here in the US, but might be useful, just like the issues of neonatal tetanus are more of use in the developing world. There were unanswered questions, though. The challenges remain regarding this next generation of rotavirus vaccines, and I want to mention, I think, 6. We'll find out. So the first one is, will live oral rotavirus vaccine work well for children in the developing world? And remember, that first vaccine 2 decades ago was the RIT-4237, which worked well in Finnish children and not in the developing world. And it's been increasingly common, not just with the vertical transmission of HIV, but with many infectious diseases, to find that it's different, developed versus developing world, but specifically with regards to the vaccines, that vaccines perform less well in developing world country populations. And these disparities mean that trials of vaccines really are needed in developing world before introducing them in their settings, because in the developing world, every dollar counts. And you really need to be able to justify that you really are reducing the severe cases of rotavirus. Just to reduce the moderate cases, which wouldn't lead to significant morbidity and mortality, are probably not cost effective enough. And so we need then incentives to be doing studies simultaneously. And will that happen? The next question that has to come up is, will these vaccines be safe? So it turns out that even when you study over 60,000 children, it's not going to prove whether they're safer than RotaShield. In a sense, we're only going to know that after post-licensure surveillance. And then, of course, comes the question, what will they cost and how can we pay for them? And again, here I want to give credit to the Bill and Melinda Gates Foundation and the other groups that have started to do the public-private partnerships, and GAVI and EPI and many of these other organizations, which are now making it such that even if the research makes these vaccines expensive, that these will be available to individuals who need these vaccines the most. The next question is, who will provide the bulk of the vaccine supply? And again, here I pointed out that part of the way to reduce the cost will be for the manufacturers in the developing world itself, and many programs have been started in India, China, and Indonesia. The fifth issue is, will countries be interested in the new rotavirus vaccine? And that's both, will physicians, for example, in the US want to do it, or are they scared because of their previous experience? Are parents going to be interested, given the history? Despite global estimates of the enormous burden of rotavirus diarrhea, few policymakers actually have adequate data to assess the burden of rotavirus in their own countries in the early years of the new century. And so actually surveillance networks were set up in different regions to try to develop a global database. And what we found was that the true burden of rotavirus diarrhea is much greater than previously expected. So even if rotavirus only accounts for about 5% of diarrhea in children, we thought it counted for about 1/3 of cases that end up being hospitalized, and it turns out in much of the developing world it accounts for at least half of the cases. So it makes the use for one cause of diarrhea, for one vaccine for only one cause of diarrhea, very, very important from a benefit-risk calculation. And again, will countries be interested with the disease of the most impoverished nation, a program funded again by the Bill and Melinda Gates Foundation, was looking to actually help provide this type of information. And the next question is, will parents accept a vaccine for only one cause of childhood diarrhea? So the fact is, if the average kid gets 10 to 12 cases of diarrhea in the first 5 years of life, how are you going to know that the vaccine was effective as a parent who might not be getting a stool culture with every case of diarrhea? And the fact is, we have lots of vaccines that only take care of part of the issue. The H flu vaccine, the pneumococcal, are only taking care of one strain. They're taking care of the strain that leads to the serious morbidity and mortality. And the fact is, we shouldn't underestimate our parents. They understand this, and they are accepting of it with those diseases. No reason they shouldn't be able to accept it with the rotavirus. So at the time, the future of an RV vaccine in December of 2004 is that GAVI had identified that the development and introduction of rotavirus vaccine was one of their 3 key priorities. And the rotavirus vaccine program, a $30 million effort funded for 3 years, was to achieve these goals. With the goal to accelerate licensure, specifically addressing whether these vaccines are safe and efficacious for children in the poorest countries, where support for the purchase may be facilitated through the vaccine fund. There were also additional efforts were needed to encourage work on vaccines in the earlier stages of development, including those being prepared by emerging manufacturers in the developing world. And at that time, there were 4 organizations funded by the Bill and Melinda Gates Foundation working with an Indian manufacturer to develop the Indian neonatal vaccine for rotavirus as the first vaccine for India. So a lot was going on, a lot due to private philanthropy. In January of this past year, 2 new rotavirus vaccines were approved, Rotarix from GSK, the monovalent vaccine, as I've already mentioned, and Rotatech from Merck, with really impressive results. And yet, efficacy-wise, and yet the long-term safety will only be known in the future. But the one thing we came to realize with the post-analysis of the cases of intussusception, so why was it that it was occurring in the first week after the first dose? It turned out it was very age-dependent, that intussusception is much more likely in children over 3 months of age. So if you actually start the vaccines before the age of 3 months, you actually reduce the risk, one, of having rotavirus infection, but you also reduce the risk of intussusception. And so whether these vaccines are actually safer than the RotaShield may never be known, because the one thing we all know is that we're going to be starting these vaccines at 6 to 8 weeks to try to prevent additional cases of intussusception. So both are being given, as I just said, before 3 months of age. Now, neither of these large studies found evidence for an increased risk of intussusception. Part of that may be because of the insistence that we don't do catch-up vaccines, but we're starting it under the age of 3 months. And whether it will be effective in other populations, so in other countries where they have different rotavirus antigens, there are numerous antigens for rotavirus, is still unknown. I gave this chart just to give an idea of what this of what the DOMI program is trying to do, which is to look at all the different stakeholders and to understand as we're studying these vaccines, and this is an example from the typhoid vaccine, will it be implemented in the countries in which we may want to do the research? And so data is being collected in the countries, looking for, is the prospective disease burden studies being done? Is there a meta-analysis of that? Is there an assessment of feasibility, acceptability, and impact? What's the cost of illness studies? What's the cost of vaccine delivery studies? Cost effectiveness analysis, assessment of demand and willingness to pay, whether at the individual or at the government level, as well as policy analysis. And so with typhoid, clearly it would be ethical to be doing this research in China and India, and it may not be ethical to be doing this research in Bangladesh, where much of this information is unknown. And so why subject anyone to the risks of being in research if we don't think it's going to be benefiting that same community in the short-term future? So the financing of these new rotavirus vaccines, what you have to know is the Rotatech at Merck is $63 a dose, or $189 per child. So 7 years later, the price has gone up by over twofold. Rotarix has a similar financing, but in at least the Latin American markets, there is a commitment to tiered pricing, a strategy to lower the cost of vaccines substantially in the public sector markets in these countries. And so, for example, in Brazil, the GSK, the Rotarix, has been being offered at $7 per dose, and since it's only a 2-dose vaccine, at $14 per child. And again, the private philanthropy, which will be helping to defray the costs. So the rotavirus saga, or the rotavirus vaccine saga to be more accurate, is it a success story or is it a failure? Well, the unanticipated setback to the RotaShield vaccine after 2 decades of research, the impressive thing is that within 7 years, we do have 2 new vaccines on the market, with others on the horizon. And that's impressive given that it was 20 years before we got the first RotaShield vaccines. Whether these vaccines, though, are safer than RotaShield will only be known in the years to come. And clearly what we have learned is we'll decrease intussusception by ensuring that we give the vaccine at a safer time in the child's life. However, in the intervening 7 years, over 3 million children died in the developing world. And how long before these vaccines will actually be studied in many of these countries in order that we can develop the financing and infrastructure will determine how many additional children will needlessly die. I'm optimistic that the infrastructure and funding available from things like GAVI, DOMI, EPI, and other public-private partnerships will become available, and this will be affordable within the decade. But I regret the lost 7 years and the additional years until this infrastructure is fully in place. And so my concluding thoughts, what are lessons learned? First, although there's only one ethical standard for research ethics, it applies differently depending on the socioeconomic circumstances. The suspension of RotaShield in the US was morally appropriate. The decision by the governments and not the ethicists of developing countries not to continue testing may have appeared to be the moral high ground, but they did so on the back of their most vulnerable citizens, those children under the age of 5. And yet, the saga has taught us important lessons. There's a need for parallel testing of vaccines in industrialized and developing countries. There's a need for multiple sources of innovation. Depending on one vaccine company may not be adequate. And that clearly the other thing we've really learned, which will benefit both children in the developing as well as in the developed world, is that the age of immunization may be critical. These lessons, if learned, may partly compensate for the over 3 million unnecessary deaths. And it will only compensate if it prevents other delays in vaccine development and distribution in the communities that need them most. Thank you very much.
Thanks, Lainie. We'll have you stay up here, and Sarah and Tanya and Dan, if you want to come up as well. Now it's your turn. This is your opportunity to engage these 4 speakers.
I'm interested if you have any comments or if there's any update on the Oregon experience. To my knowledge, Oregon is one of the few states that actually had a plan. I don't know if it's through public health or the state or what, where they actually said we have limited resources, there are ethical dilemmas, we have to make decisions. And I thought what I read about a few years ago was quite brave and appropriate in their part, but I don't know what's happened with that experience.
How much time do we have? I'll finish sometime tomorrow afternoon. it was one of the most fascinating chapters of American health policy, and of course, you're exactly right. The state did decide that, at least for the people who are in the same income range as Medicaid recipients, they would, instead of, as they say, rationing people and only covering half of the poor people of the state, they would cover everybody but with a limited set of services, and they tried to arrive at a decision about which they would be through a very elaborate and rational process, bringing in a number of well-known experts in health economics and also involving the public. Now, I actually did several weeks of field interviews and talked to almost everybody who'd been involved in the leadership. And I came away with the impression, with the conviction at the end that, first of all, it was a runaway success. The reason it was a runaway success was that it gave the impression of being a scientific enterprise. And people liked that so much that the legislators added a lot of money to it, which is what made it a runaway success. So as a model for how we should do such things in the future, I think there's too much to criticize, but it was remarkable then. The one thing that's surprising is that it really has not been followed up on. The state of Arkansas recently got a waiver of for some Medicaid work that looked a little bit like it, but it's really not as thoroughgoing as that. And West Virginia is doing something that's also quite innovative, although a little bit frightening. So it's probably emboldened some local officials to try to do something a bit like that, but nothing as comprehensive and sweeping.
My comment goes basically to Dr. Virafana, and it's regarding the rights of children and adolescents as subjects of research. It seems to me that other people are making the choices, and should we be talking about assent? Should we be talking about consent, particularly when we're dealing with adolescents?
The reason I presented it that way is because in many of those countries, adolescents do not have a legal, are not able legally to consent for themselves. They're still considered to be, to require parental consent for participation in trials until the age of 21 in many countries. So what I was presenting was really, I agree with you that there has to be programs and ways of trying to enable adolescents to actually make empowered decisions for themselves. But the reality is in many countries that just may not fly. And the decision for them to participate in trials will have to be made in concert with their legal guardians or parents. And the issue of assent was brought up in that case. If countries will allow assent of an adolescent, then that they should be allowed to do so. So I actually support what you're saying and advocate for that, but the reality is in many countries that may just not be the case.
And I'll argue for the other position. I'll argue very much that parents should be involved, that research isn't the same as a clinical service, and that if we don't know that these vaccines are safe, and if we don't know that these vaccines are effective, I don't think we should be empowering kids who don't have, in a sense, the same amount of clinical judgment that maybe their adult parents have, and that I would want this to be a joint decision between the parents and the children, and would not like to see that HIV vaccines are being done in countries where they can get away with, quote, just the child's assent and not requiring parental involvement.
Dr. Corey?
Yeah, well, the issue of enrolling adolescents into HIV vaccine trials has been, as Tanya said, a very complicated one and a difficult one. Obviously, for us trying to take the population at great risk, you only have to look at the data from South Africa, where you see adolescent girls starting to get HIV at between 12 and having incidence rates on a population basis of 8 to 9% per year between the ages of 12 and 18, to want to say that if you're going to have a vaccine and you want it to make an effect, you would want to do it in the population that is most effective. But as Tanya said, South Africa is a country that doesn't allow informed consent by any individual less than 21. So, we've spent a lot of time actually sort of working through the issues. It's all further complicated by the issue that if you get the money from the U.S. government, the ethical review of the U.S. government and the FDA also leads to the issue of, are the risk benefits for adolescents in the United States really very different than the risk benefits that go with the adolescents in sub-Saharan Africa? I think it's pretty obvious to all of us that there are different risks and benefits, and which culture and which, it's not the issue of the safeguards, because I think the safeguards are the same, but some of the processes are difficult. I'll just say that it's an issue in which there are many sides, and you sit at the table to try and hammer out what seems to be an agreement, and I think we finally have something that actually is on the boards that is starting to wind its way through to try and enroll adolescents in vaccines that really look like they're in efficacy trials. I mean, again, one would not want to take an experimental vaccine that you really have no ideas in advanced clinical development, at least in my opinion, and that's been our policy, not move it forward until at least it is truly in efficacy trials in adults to even start the program. And just to say that the field has spent a lot of time on it, there's still many issues, but there actually is some progress, and actually a protocol with the intent to actually start something in 2007 in the Republic of South Africa for an HIV vaccine in adolescents is hopefully going to go forward.
So I guess I give a lot of credibility to that parents aren't dumb. And if you told me, if I were a parent in sub-Saharan Africa, that my 12-year-old daughter had an 8 to 10% risk of developing HIV every year, I think I would sign her up for an efficacy trial, and I think many parents would. So I'm not convinced that we need to be doing these with just the adolescent's consent or permission alone. I think that parents aren't dumb. They understand. They know when they started sex. They know when their kids are going to be having sex. And we should give a lot of credibility in working with the whole community, because the fact is that HIV and AIDS isn't just about teenagers having sex. It's about a community and a social world. And so this whole idea of creating research with adolescents without parental permission is suggesting either that they're smart enough to be making good decisions about cost-benefit analysis when we don't think that they make good decisions in any other aspect of their lives.
I hope you didn't construe that I felt any other way other than parental consent. We are moving forward with parental consent, so I hope you didn't construe that I was thinking.
I just want to make sure we're not talking about adolescent consent alone for research.
Actually, just to clarify, I think in the adolescent field for HIV, there's been discussion having both parental consent as well as assent of the adolescent, but having both things. And I would agree with you that, in fact, what we should be focusing on is advocacy among the parents to help them encourage them to have their children involved in this research. And in fact, in Botswana, Dawn Smith with the CDC has done quite a bit of advocacy work to try to do that and encourage parents in having their children participate in the research. So.
And we'll end with you, Ed.
Just a quick question, getting at the issue of integrating ethics into decision making. I'm troubled when what seems like it is rational and what seems like it's ethical turns out to be unacceptable. And it sounds like that's what happened with the use of Rotazyme in the developing world. It might have been rational. It apparently, based on the discussion today, would have been ethical, but it was clearly unacceptable to the leaders of that world.
Well, I saw that as a failure of leadership. It's fine to bow to political realities and so on, say that people aren't interested, unless the stakes are really high. They were. You know, we heard with the figure how many people died because of this. And it goes back to when I was at WHO, there was a famous story. Jonathan Mann, who was, many of you know, was one of the early people working on AIDS issues. Went to the then Director General, and he said, you know, listen, there's this new infection, and it's right now only in a few pockets, but it's really lethal. And if this genie gets out of the bottle, the world's going to be in big trouble. And the Director General said, well, we're not getting any expressions of interest from the member states on this. And he said, they don't know about it, but they're all sitting ducks and there's going to be devastation. And he said, well, we serve the member states, and when they tell us that they'd like us to do this, we'll do it. History won't remember that very well.
And I would just like to echo that. I think it was unacceptable to those who wanted to make political grandstand. I'm not sure that the voices of the community were actually heard, because again, I think if we asked the stakeholders, the parents of these young children, would they be willing to take the risk? I think they would have jumped on it even at a risk of 1 in 2,500, but clearly would have jumped on it at 1 in 12,500. And I think then that politicians are often not necessarily in tune with the communities in which they serve.
We'll end on that note. Let's thank our panelists for a great discussion.
You have been watching a session from the 2006 Pediatric Bioethics Conference, Ethical Issues Related to Vaccination of Children, presented by the Treuman Katz Center for Pediatric Bioethics at Children's Hospital in Seattle. For more information about immunizations, please visit the websites listed here or go to seattlechildrens.org/bioethics. The Childhood Immunization Schedule, www.cdc.gov. The Immunization Action Coalition, www.immunize.org. The Influenza homepage, www.cdc.gov/flu.